let's swing this around a little bit, and you've been poking at the edges of this issue, which is cardiovascular disease, and then the implications of this disease for payers.
Yeah, again, the
for you know, whatever, one in every what percent of all the healthcare dollars is spent on this?
Probably 25 to 35% of the overall healthcare dollars are somehow related to cardiovascular disease.
So we're talking billions of dollars.
That's huge. Yeah, exactly. But again,
the look on his face, by the way, it's huge.
Yeah, huge, no pun intended, right?
That's
it's
right.
Huge. But again, I think it's less. There's less emphasis on the pharmacy side right now. It's the medical side.
Okay.
So, and it's the link with the comorbidities that we've been talking about, diabetes and weight. I mean, if you combine those disease states, I mean, this is really an epidemic, and so we have to do a better job. So the implications are we have to do everything we can from a payer perspective to address that, because I think payers working with providers are in a very unique position because we have the data. So we know what other patients are doing. We know if they're refilling their medications. We know what they're doing. So again, it's building out and making sure you have really good medication therapy management programs, that you have very good disease management programs that are different than the traditional care management or disease management programs. Again, it's more interventional. So that's, I think, the other trend is, I think a lot of people are moving away from just the traditional longitudinal disease management and are trying to focus more on the interventional component.
Okay.
So it's looking at data, it's looking at claims to see if they've missed, if they're not seeing a doctor, if they're missing medications, if they have other things going on, and trying to predict if they're heading to an event and reaching out before, because it's much easier to prevent than it is to treat.
You know what I hear here, which is fascinating to me as a clinician. The assumption of the clinicians in this world is that they're providing care and you're funding it. But what I'm hearing from you is more engagement than that.
Right.
That you're looking at folks proactively, you're looking to see who's involved. Do you feel that from the managed care perspective, you can actually manage healthcare as opposed to just pay for it? What do you think?
Well, I'm biased.
I know you're biased.
I think so.
I think you can. I mean, I think back, I come from a primary care setting that's a private practice, and there's busy physicians, and what they simply do is they see 30 patients a day, and they prescribe a statin, and they give it to the patient and send them out the door. And that's not managing their care. I think the predictive modeling is important, so we can try to predict those patients who are going to be at risk for high-cost health care, whether it be admissions to hospitals or ERs or whatnot, and manage that care.
It's also when you're looking through their drug profiles and you're noticing things, it's that communication back to the provider is closing that loop, and that's the key, and I think that's where a lot of people struggle.
But is there buy-in from the clinician side? In other words, I understand what you're trying to do. But when you call, do you actually call physicians and say, look, I saw that Ms. Jones didn't refill this?
Absolutely.
And what are the physicians
There is
say?
more. I think a lot of it is driven by ACO, patient-centered medical home. Just this changes in the healthcare delivery system over the last 5 or 10 years. I think there is a lot more interest in collaboration because the providers realize that they don't have the resources. So we're not practicing medicine. We're not telling them what to do. It's consultative, it's collaborative, and but absolutely.
Yeah, I think more we integrate the delivery network, we'll see more of that collaboration, not only focusing in on pharmacy claims, but you pointed to medical claims data and looking 360 at what's happening to that patient to be able to address total medication and therapy management. And
part of that is the risk, the spreading of risk. So before, really payers / employers were the ones that bore the brunt of medical costs. And now we're trying to figure out how we get pharma in that.
Okay.
We're figuring out how we get providers into that. So as risk changes a little bit, the incentives become more aligned, and I think that's what's opening the door for us to collaborate better with providers.
Yeah, I agree. With our practice being a part of an ACO, that's important now because we have quality measures we have to meet, and if we don't meet those measures, then it affects our reimbursements. So from that standpoint, it affects it big time. So the collaboration is a lot more open than it used to be. Before, it sometimes could be intrusive in a busy day. And I don't think it's viewed upon that, at least in the private practice that I'm associated with.
I think as a clinician, if I were in an office seeing all these patients, I'd like somebody backstopping me.
Yeah.
I'd like that phone call coming in, let's say at 5 o'clock, whenever it would come in, saying, we checked your list of patients. Ms. Jones didn't renew. Mr. Jackson didn't do this. Maybe you want to go back and have a look. I think that would be great. Aren't the physicians really buying in on this?
It's across the board.
There's a quizzical look on your face.
No, I mean, it runs the gamut of providers.
Who wouldn't want help?
Right.
No? No, I'm serious. Who doesn't want help?
Well, I'll tell you, so we actually have taken it almost a step further. So having a a company that's doing a lot of this legwork, giving us the data, and then using people like me who are integrated in the practice to relay the message to the physicians. So I've worked with these physicians for several years, and then I bring the recommendations to them firsthand instead of via fax or via phone, and those things are working.
Okay, so we're living in nirvana now. Everybody who has hypercholesterolemia is getting treated. Everybody's on the right drug. Not. Right? What population of people don't, in this country, don't have their lipid levels under control right now?
Well, I think speaking from a private practice standpoint, probably the biggest ones I see, of course, are your non-compliant, which we've discussed. But also one group is your statin intolerant patients. So we have a fairly large population, maybe more so than what the literature would indicate that it actually occurs, and maybe some of that's fear, patient education, that type of thing. But those patients that are statin intolerant have difficulty meeting their goals. And the other population I think about are the patients that start with a really high LDL. Maybe they have already advanced cardiovascular disease, so maybe it's familial hyperlipidemia, but those patients are difficult to meet their goal despite maybe they're getting treatment. But I think those patients, statin intolerant patients, those patients that are non-compliant, are a big patient population that I see that are not getting treated appropriately. And it's also the other thing is it's a symptomless disease. It's an asymptomatic disease, and that's one of the most difficult diseases to get patients to be.
Is it that people aren't getting screened? In other words, patient comes to a doctor's office. It's likely the doctor should be screening for hypercholesterolemia. So are you saying that the docs aren't screening, patients aren't coming in, or once diagnosed, patients aren't doing it?
No, I think they're being screened. I think in our practice, they're getting screened. We're knowing what their LDLs are and what their goals are and so forth. It's just getting the patient to actually take therapy. Whether it be a fear they've heard their neighbor had an adverse reaction to a statin and they're not going to take it, or whether they've actually truly had an adverse reaction to a statin.
I just want to throw this one question in, because in my clinical experience, which is hospital-based, the number of people who have actually had a problem with a statin is quite small.
Yes.
But the number of people who claim to have had a problem is
Exactly.
quite large.
Exactly.
So why this disconnect?
Some of it, I think, is the way we educate people because we want them to know the serious adverse effects that could happen. But then they think they're having an adverse effect. And I always educate students. We hear it's a small part, probably 30% of the people I see actually complain of some sort of myalgia. No, not small at all.
That's not small at all.
So what we're taught is a small adverse reaction in practice is much larger. Whether it's real or not is the question.
So it's a serious problem. Not just adverse effects from statins, but the whole rolling patients into an effective treatment program is big.
The other thing I think that's an issue is just consistent application of the guidelines. I mean, we had the ATP3 guidelines, now we have the ACC, AHA guidelines, so it depends, the consistency of the guidelines being applied to practitioners' practice, I think, is an issue as well. And I think just fragmented care. I mean, I see that a lot on the private practice side. The patient goes into the hospital, something happens, they get a stent. They come back to the primary care practice. The cardiologist that's managing the stent really didn't manage their lipids, so there's a little bit of fragmented care, and I think that leads to
Everything's
issues
in a
too.
silo.
I mean, that's an interesting point, because the guideline change was not insignificant.
Right.
And I think a lot of providers still manage to an LDL, but the way the guidelines are written, it's a little bit more difficult to identify a patient and probably manage a patient to a goal.